Good evening, good afternoon, and good morning, everyone. Welcome and thank you for joining us today. We're about to begin. In today's session on evidence and data-informed COVID risk communications, we will get to examine how the Partnership for Evidence-Based Response Against COVID-19, or PERC, can support your efforts. We will discuss how we'll identify approaches for refining messaging based on the latest data, and also hear and share insights on risk communications challenges and lessons. I'm Jobin Abraham, joined by my colleague April Budd here at Vital Strategies. Together, we will be moderating the session for you today. Vital Strategies is a global health organization that works with governments and civil society around the world to tackle the most pressing public health problems. Right now, our organization has pivoted to supporting the COVID-19 response. Before we get started, let me just share a few quick housekeeping rules. During the course of the session, we want this to be a very active, interactive session. So there will be times when we are looking for your questions. So as our panelists are presenting and you have questions, please enter your questions for our panelists so we can address them in the Q&A session. If you have any particular need for technical support, please use the chat feature. And at various points, we will be polling you to get your feedback or understand what it looks like in your country context. So please participate in those polls. This session will be recorded, and we will be sharing the recordings and the files associated with this presentation within a day or so after the session. So to move forward, today we have three wonderful speakers here to speak with you. We have Dr. Nandita Murtkola, Vice President of Vital Strategies, Dr. Hannah Rohan, Assistant Professor in Social Sciences for the UK Public Health Rapid Support Team, who's currently deployed to support Africa CDC. Nandita and Hannah will be talking to you about the findings of the report and what the implications would be for you. But to start us off today, we have Amanda McClelland, Senior Vice President at Vital Strategies, who's leading our COVID response. Amanda has more than 15 years of experience in international public health management. She's previously served as Global Emergency Health Advisor for the International Federation of the Red Cross and Red Crescent, where she focused on emergency health, epidemic control, mass casualty in low resource settings, disease prevention, and response operations. Amanda, I'll hand it off to you to get us started today.
Great, thanks so much, Jobin, and welcome to everyone joining us online. I'm just really going to introduce the initial reason that we put the PERC partnership together. So as Jobin mentioned, we as Vital Strategies and the Prevent Epidemics team within Vital Strategies, collaborating with Africa CDC, the World Health Organization, London School of Tropical Medicine, the World Economic Forum, and also combining the public health knowledge with private sector using in the partnership Ipsos and Noveta to really bring market expertise and data analysis to the platform. So the reason that we started the partnership was really the main reason. Everyone's seen the flatten the curve epidemic slide here. This idea of delaying the epidemic, reducing the height of the peak to be able to improve health facility capacity, really protect the health system and the healthcare workers, not just about ventilators and critical care, but about ensuring access to PPE and putting in those administrative and environmental controls for IPC, building up public health capacity for track, trace and treat, and to buy time for the development of treatment and vaccines. The issue that came up very early was that a number of the measures that we were seeing being successfully used to slow transmission and to flatten the curve, especially in Southeast Asia, were going to cause difficulties within the African context. And acknowledging early on that best practice required early engagement with communities to ensure that they understood or to capture the ability of communities to adhere to physical distancing and social measures. And so we started with a small pilot in Nigeria and Ethiopia, and at the request of Africa CDC, we reached out to the partners to expand that work to the continent. So one of the challenges when we're looking at physical distancing and social measures that's becoming very clear in terms of a gap in knowledge is how severe the outbreak or the pandemic will be in Africa. And what you see here is the pandemic severity assessment framework that many countries use to assess where we are in terms of severity. And you'll see here that unlike other pandemics that are shown here on the slide from 1918 up in the right hand corner all the way down to 2011 outbreak down in the bottom left hand corner, there's no one size fits all in terms of severity. We are seeing the infectiousness of the disease is very clear, it's highly infectious, but the impact of the severity is changing based on age demographics and vulnerability. And so we've been using this breakout of the pandemic severity framework to help us understand what the outbreak might look like in different contexts, and therefore the types of physical distancing and social measures that may be needed. And as you can see on this slide, you know, countries are asking real and challenging questions. If you're in Sierra Leone right now, the average age within Sierra Leone is 19.4 years. And so does that mean that this outbreak is within the seasonal influenza range and really quite low? And should they be using pandemic type measures? But what happens to the rest of their population? How does it impact their health system? What does implementation of physical distancing do to their economy and other social disruptions? And so this was really the questions we were receiving from countries that led to the impetus of forming this partnership to try to pull together some of these data sources and to try to provide at least a framework for countries to be able to analyze this data and make decisions based on finding the balance in their context. So one of the main frameworks driving the partnership is this idea of balancing the health impacts on the top of the curve and limiting or mitigating the economic and social disruption on the bottom of the curve. And this idea that this is not one wave and done, that this will be the new normal for some time to come, at least 12 to 18 months at a minimum, until we get access to reliable supply of vaccines. And so the framework really driving the initiative of this idea is really how do we provide the right data to find the balance between health outcomes, economic and social disruption, and how do we best support governments to engage with their communities for local adaptation and local mitigation measures. So these questions really we tried to address in the report. We don't have all of the answers. We are learning together. We will continue to bring these data sources together and present them to partners in a weekly basis and present regional reports every 4 to 6 weeks. But essentially, we're really looking at how PHSMs are changing the transmission dynamics. And you can just see in the graph here how difficult that can be. This is the 3-day moving average of an example country with lots of different PHSMs being implemented at different times. So how do we help governments and partners understand the impact of the right PHSMs, when and how to use them? How do communities understand why PHSMs are needed? Do communities have the resources to effectively implement and adhere to the PHSMs to keep themselves and their families safe? As well as what are the barriers to that adherence, and how can we adapt and mitigate these PHSMs to improve adherence and reduce negative impacts? So they're the questions that we really started with in terms of how this partnership could bring value. And the collaboration that we formed under the PERC label.
Amanda, just a quick clarification. We've got a couple of questions already about what we mean by PHSMs. If we could just...
Yes, my apologies. So what we mean by PHSMs, it was known by the name non-pharmaceutical interventions. and now under WHO leadership has been moved to public health and social measures. It relates to the measures that are non-clinical, non-treatment, non-in-facility measures that we use to slow transmission. So it includes things like personal, what we call personal PHSMs, which is the hand washing, respiratory etiquette, keeping 6 feet apart, all the way up to the community level physical distancing measures, lockdowns or stay-at-home orders, stopping public transport, cancelling mass gatherings like entertainment and social events. So there's a range of PHSMs. We'll provide to everyone on the webinar the Africa CDC guidance and a number of guidance documents from Vital Strategies around which PHSMs work where and in which context and how to turn them on and off, or suggested ways to reduce or to mitigate PHSMs. Great. So over the next 40 minutes or so, Hannah and Nandita are going to go through the Newkirk Report. This will be the first report from the partnership where we've tried to bring data sources together to put not only the social science data and the epidemiology data into the context of but also including indicators around economics and security. The key recommendations from that report as a baseline report very early in the pandemic is really for countries to focus on building health capacity while the caseloads are low, to really focus on building up the ability to test, trace, isolate, and to treat cases. This is really the foundation to be able to reopen and to release public health social measures, and to make sure that countries have a good understanding of what their actual caseloads are, understanding where the risks are and where they need to respond. The second recommendation is really focused on monitoring the data and monitoring closely, using data to drive decisions, to adapt PHSMs to local conditions and needs, and to determine when and how to lift or loosen those measures to help balance lives and livelihoods. And then the third and very important recommendation that we'll focus on today for the rest of the webinar is really to engage communities and engage them not only in terms of one-way communication, but to work with them to adapt the physical distancing and social measures to the local context, effectively communicate about the risk to sustain public support and achieve widespread adherence, and also to support shielding of vulnerable populations. Jobin?
Thank you, Amanda, for that introduction to the purpose of the PERC partnership and this primer on public health social measures. It's now my pleasure to introduce our next speaker, Nandita Burkutla. Nandita is a social psychologist with expertise in social and behavior change. At Vital Strategies, she leads a team that produces policy analyses, research, and evaluations that help policymakers and program managers to make informed decisions about public policies and communication strategies. As part of the COVID-19 response, Nandita coordinates a team that collects and analyzes different streams of data to enable the effective implementation of public health social measures. Welcome, Nandita. And to introduce Nandita's section of the discussion, we'll actually start with a poll. In a moment, you will see a poll appear in front of your screen that will have the question: which types of data are you using to inform your local decision making? Please select all that apply. And these options are testing data, epidemiologic data, data from print and social media, mobility data, surveys of urban residents, incidents of unrest and violence. April, could you please activate the poll? Please enter your responses, and in a few seconds, we will wrap up the poll and have a quick discussion before we start Nandita's presentation. A lot of you are jumping right in. So there are over 100 people on today's call today, and we already have about 50% of your responses. So in about 10 to 15 seconds, we will wrap up the poll. Nandita, can you see the results in front of your screen?
Yes, I can.
Excellent. So take it away.
All right, thank you. First of all, thank you all for being here with us this morning or afternoon, evening, wherever you are. In terms of the poll results, I think you can all see that in front of you on the screen as well. 80% of you use epidemiological data, 56% use testing data, 47% use data from print, social media, and I see that between 20 to 25% use mobility data, surveys, as well as incidents of unrest and violence. And thank you for that feedback. And it's a great segue, in fact, to the findings from this report. In the PERC report that I hope you all have access to and have had a look at, you'll see that we've described data from most of these sources that you've described as data sources for you. And we hope you will continue to use the data available to you via PERC. In my presentation today, I will focus on the behavioral data and its implications for risk communication. Fundamentally, public health social measures require behavior change and on a massive scale and over a long period of time. Behavior change is well understood and known to risk communicators, but in the context of COVID, it is the scale and it is the period of time that make it a particular challenge. In order then for public health social measures to be implemented effectively, it's crucial that public acceptance and the ability to adhere are considered. And so optimal implementation must factor this in. It must factor in the public experience of the public health social measures, and it must be adaptive so that it balances public health needs on the one hand, but also societal and economic impacts. And in all of this, effective risk communication and community engagement will be key as a tool to build public trust, engagement on the public health guidance, and ultimately to ensure adherence with those guidelines. Now, the PERC data, as I've mentioned it, has a number of different streams of data from epidemiological data to data on security and violence. The focus of my presentation will be on the social and behavioral data. This data will be continually and periodically updated and shared, and therefore we hope that it will be useful to you in a continual communication programming cycle to guide from strategic development through program implementation and ultimately the evaluation of your efforts. Now, what I present before you are the key findings from the report and some of those implications for risk communication, but there's a lot more rich data available to you through the reports as well as the accompanying briefing notes and risk communication best practice guidance. What we found fundamentally is that awareness of COVID was very high. It was nearly universal in all the countries in which we conducted the survey. Those were 20 countries, urban areas in countries to really get at what the experience is in high population density parts of those countries. And we found awareness is high, knowledge of COVID, what it is high. But what people lack is information on self-protection and treatment, and there is a demand for this information. What we also found is that misinformation and uncertainty persist, particularly around alternative remedies. We found some confusion or uncertainty about how to respond or deal with those who recovered from COVID, and we found traces of prejudice, such as towards the Chinese, or in terms of it being a bioweapon by the government. What all of this means for risk communication is this. It will be important to communicate honestly and proactively. Given the scientific uncertainty around COVID and the evolving science, accepting uncertainty will be key and a way of building trust with communities. It will be critical to address misinformation, and the best way to do so will be through frequent, up-to-date information provided via trusted sources. And it will be crucial to anticipate and address stigma. Uncertainty can lead to stigma, to rumors, and often tap into latent prejudices that exist within society. So anticipating this, knowing it might happen, and addressing it through empathetic communication will be important. Another key finding from our report was that while the majority perceive COVID-19 as a big problem for their country, perceptions of personal risk were itself lower. So many more see COVID-19 as a big problem for their countries than they do the risk of catching COVID themselves. What this means from a risk communication perspective is this. We know from decades of social psychology and social sciences and communication experiences that it is emotional reactions that lead to behavior change and to adherence with public health guidance. So what people know, they have to feel, and from that feeling comes the compliance or adherence with guidance. And so in this context, it means risk communication efforts will need to build that personal risk perception, but also link personal risk with the notion of community risk, the shared risk in the community, and the importance of adhering with this guidance for the collective good. We also found at baseline high confidence and trust in the government response. And we found that the support for public health social measures was high across the board, across countries. Higher, of course, for those personal measures, but also for closures. It was remarkably high for closures of marketplaces, workplaces, and so on. Likely at this early stage, it reflects the satisfaction and trust in the government information being provided, and it is in response to the anticipated burden. But from a risk communication perspective, what this means is the high satisfaction and trust, which is an opportunity now, must be maintained and strengthened. That high trust in the information received must be protected. Trust is crucial, especially in the uncertain circumstances in which communication is provided. Trust is crucial to building public engagement, acceptance, and ultimately adherence. So it must be maintained. But part of that maintenance will be accepting the limitations of a government response. So we would suggest and present that high confidence that people experience and feel now must be protected by also making clear what are the limits of this response by the government. And meeting and managing these expectations will be crucial to prevent later dissatisfaction. Communicating honestly the limits of a government response to the pandemic is crucial, and maintaining and building upon this trust and confidence will be the priority. We measured what would be the barriers of the public health social measures guidance, and we found that the barriers are significant, particularly with stay-at-home orders and closures. A significant proportion of the population will run out of food and water, run out of money, and most people do not have the physical space to isolate the sick. What this means for policy development and also for risk communication efforts is that the guidance will need to be tailored and will need to be managed to be appropriate to the communities that are being urged to comply with them. And risk and community engagement and needs assessment with communities to understand and engage with them to modify the guidance will be crucial, as well as instituting relief measures to make implementation of these measures more practical. Next slide, please. And finally, we looked at the sources of information people access, as well as their most trusted sources of information. And we found that TV and radio are highly used continent-wide, as are WhatsApp and Facebook. The exact numbers and details are present in the report, so I won't belabor that, but mass media is well utilized across the continent. And we found that the most trusted spokespeople for health information were medical authorities, including within the government, as well as religious leaders. We also found that political leaders were less trusted, although the presidential offices tended to receive high levels of trust and support. So our recommendations for risk communication are leverage mass media, where we're finding, and we know from previous experiences with crises, that during such situations, the public becomes more reliant on news media and mass media. So this is an opportunity to use them best. Also identify and engage local community leaders and trusted spokespeople. Our data suggests for you what will be the most trusted spokespeople, but confirmation of that, in particular identification of specific individuals as spokespeople within communities, will be key. So in conclusion, there are certain practical and particular communication challenges around COVID-19, and they are these. One is that the reality is there is a lot of scientific uncertainty around COVID-19, and as the science develops and as we learn more information, we will need to manage that uncertainty and prevent it from leading to misinformation and potential stigma. And stigma is often applied to already disenfranchised groups within communities. To do this, honest communication, proactive, frequent communication via trusted sources will be crucial. We also recognize that personal risk and the perceptions of personal risk is crucial in the case of any crisis. But in this particular context, it will need to be understood that personal risk perceptions must be maintained over the multiple anticipated waves. So it isn't a single event, but this is something that people have to stay in over the long haul, and understanding this will be crucial. In that context, social cohesion and acting in the collective good will be necessary. And one portion of this, one part of why this is necessary is if people understand and they self-comply with this guidance, then self-enforcement is how public health social measures will get implemented. It will reduce the burden on other forms of enforcement, including the securitization of public health social measures, which will be ultimately in the greater social good. And finally, maintaining confidence and trust will be crucial. In the short run, it might be easy to gain, but honest communication, accepting uncertainties, and soliciting partnership with communities will be key to maintaining this in the long run, particularly as burdens accumulate and as relief measures are put in place to address those burdens. And so finally, evidence-based risk communication and community engagement will be key, but evidence-driven, so using data to understand where the population is at, where communities at, and what their needs are will be crucial. And we hope that the PERC platform will provide you that kind of data for continual use. Providing prompt, honest, coordinated information that is tailored not just to the local context, but to the stage of the epidemic will be key. Managing misinformation will be key, and the most effective way to do this is through proactive, honest, and empathetic communication. Explaining the rationale for public health social measures, sharing that burden with communities will be crucial to getting their acceptance, their engagement, and partnership. Improving risk perceptions, but also promoting social cohesion is important. And ultimately engaging trusted community leaders, which includes faith leaders and others, in a two-way dialogue to ensure that communication is continually learning and utilizes mass media optimally is required. So with that, I conclude. Thank you.
Thank you so much, Nandita, for that overview of the report findings. Now we'll actually spend a little bit of time, as we mentioned, in our introduction, we're learning with and from you as much as you are from these reports. So we want to make sure that this is truly a dialogue, and we will open up now for a brief Q&A before we move into the next session. And to help with that, April, please take it away.
Thank you, and thank you for the questions that we have so far. Just a reminder to put your questions into the Q&A box and also to submit one question at a time. So we have a question that says, can you clarify the regions mentioned in the study, such as the northern and southern regions, and is the data respective to countries or general? So can you offer some clarification around the regions and countries in the study?
Yes, so we, and the full details are available, including the survey sampling, the number of respondents per category. We use the definitions as per the African Union and Africa CDC. So those are the definitions used. And in terms of representativeness, they're representative of urban areas selected within each country. We restricted this initial round of the survey data to urban areas as areas with high population density where the burdens are likely to be felt most. We have other sources of data within the PERC platform that look at other regions and other countries within Africa.
Thank you. Another question is referring to, you earlier shared a recommendation to get frequent up-to-date info from trusted sources. The question is asking, what are trusted sources apart from government organizations? Can you speak to what you mean by trusted sources?
Okay. Trusted sources are those sources whose communication is accepted by the public as believable, credible, relevant. And the trusted sources we identified in our survey, but I would suggest that other sources of data for local communities be also considered to tailor it to local needs, included medical professionals, health professionals, as well as faith leaders. Those were identified by us as trusted sources.
Thank you. Another question is, do you think that communication strategies have succeeded until now to efficiently fight COVID-19?
Okay, and I'll look to my other panelists to also offer their responses to this. It's hard to say, provide a blanket response to that because it depends on which context and which particular strategy we're speaking of. Our data certainly suggests that the government response up to this point, up to the point of when the data was collected, was effective because trust was high, confidence in the information provided was high, as was support for the public health social measures that have been recommended. All of that suggests that what information people were receiving was effective, in fact. But the challenge will be maintaining that over the longer run.
Thank you. Those are the questions for this segment. Other questions will be answered in the next Q&A.
Amanda or Hannah, did you want to chime into that last question as well? Great. Moving on. So to introduce our next speaker, we have Dr. Hannah Rohan, who will be talking to you about, now that you know a little bit about the report itself, what the implications might be for your context and how we can take the next step forward together. So Dr. Hannah Rohan is Assistant Professor in Social Sciences for the UK Public Health Rapid Support Team. The UK UK Public Health Rapid Support Team deploys rapidly to respond to outbreaks, conducts research to improve outbreak response, and conducts capacity building activities in outbreak vulnerable countries. Hannah is currently remotely deployed to support Africa CDC with COVID-19 response efforts. And to help bridge to Hannah's discussion today, we have another poll question for you because we want this to remain interactive. In a moment, you will have a poll pop up in front of you that speaks to Which of the following will be the primary focus of your next risk communication effort? We know that it's probably going to be difficult for you to select one, but please select the one that you think is going to be your primary focus. April, can you go ahead and start the second poll? We still have over 100 participants. And just for your curiosity, we have participants from all over the world signed in today. People from Ghana, the Gambia, Tanzania, Uganda, Zambia, just to name a few. And also from all development partners from all across the globe. So thank you everyone for joining in. And over 50% of you have already put in your responses. I can see that. So in about 10 to 15 seconds, we will stop the poll and reflect the results so Hannah can lead the next phase of the discussion. Excellent. Hannah, can you see the results in front of you?
And thank you, Jobin.
Great.
Hi, everyone, and thank you very much for joining us today. That's interesting. It looks pretty evenly matched with respondents implying that they are going to be targeting mainly misinformation, improving public perceptions of risk, and improving public adherence to PHSMs. And then only a very small minority, less than those, looking at addressing stigma, which is very interesting. So a nice even split there. I'm going to talk about how you can use PERC data to inform your strategies as we go forward. So I think it's very important to note that the PERC data in the current report, and that will be produced on a routine basis every 6 weeks, are reported at the regional level, so they're aggregated. Now, those data do provide really, really important insights into local perceptions of PHSM, their acceptability, and challenges to adherence. But it is important to triangulate the findings from the PERC data against locally collected data, be they data collected by ministries of health or by other implementing partners, and really understand how the information that we are providing through PERC can be complemented by the data that you collect locally. So one of our data collection streams for PERC is analyses of social and traditional media. To collect these data, we use what are called web scraping technologies to collect publicly available social and traditional media data that allow us to understand what people are saying on social and traditional media about public health and social measures, how they feel their governments are performing, and misconceptions and rumours amongst a multitude of other variables. It's important that everyone understands that these data aren't representative data like surveys in the traditional statistical sense, but that they can provide really important qualitative insights into what is being reported locally about PHSM and how people are discussing them on social media. Community feedback is increasingly seen as a critical component of risk communications activities. And alongside traditional approaches to engaging in community feedback activities, social media analysis can really help us understand what communities feel about the response in their countries. Now, obviously, the insights that these kind of media provide are limited to information from people that have good internet or smartphone access. And that's one of the reasons why I would say these data are not representative in the traditional sense. But ministries of health and partners and other response organisations can use this information to adjust intervention measures and to help make them more locally appropriate and acceptable. In communities with good internet access and smartphone penetration, social media and traditional media data can be used to conduct targeted online risk communications and community engagement activities, by responding directly to social media users' concerns. And in that way, they can help to ensure a two-way channel of communication, particularly when traditional approaches to these kinds of activities are harder than usual because of the physical distancing measures that we're all seeing implemented as a result of COVID-19. So briefly, how can you use the PERC data and how are we going to be providing them to you all? As Amanda mentioned at the beginning, we will be providing a high-level overview report every 6 weeks, and that will be available at the link provided. And I believe that all participants today will get these slides and therefore will have access to this information. You'll also all receive more routine, more frequent PERC reports from the email address noted down there. We're in the process of developing a dashboard that will provide very easily interpreted information, summarized information on acceptability barriers and the impact of the implementation of public health and social measures at the regional level. And we are about 3 weeks off, we believe, from being able to provide those. And then finally, if individual African Union member states have specific country level queries about the data that PERC can provide and need us to drill down a little further, particularly on the social media side, they can do so by contacting the Africa CDC web address indicated on the slide here. And we'd very much like to hear from you. Thank you, everybody.
Thank you, Hannah. And now that we've heard a little bit more about the implications and next steps, I invite all of our panelists to turn their cameras back on, and April will lead the closing Q&A session. Please keep your questions and answers coming through, and April will pass them along to the panelists during this session.
Thank you, Jobin. So one of the key recommendations that you made was around engaging communities. And the question is, some countries have banned social gatherings and even locked down. So how do risk communication teams engage communities? Can you talk about the tension there?
Shall I take that one? I agree, it's a very obvious challenge, and it means that traditional approaches, particularly those that we know can be more effective in a lot of communities, like face-to-face communications and social mobilization activities at the household or community level, are extremely difficult. And so we are going to have to be creative and resourceful. However, there are traditional risk communications activities that are not hindered by PHSM or by lockdowns. So mass media approaches will still work and should be utilised. As Nandita said, there is a high reliance on radio, television, and in many urban areas in particular, smartphone penetration is extremely high. And so those kind of communications channels can be utilised. And then depending on the nature and type of the community and the particular risk communications activities that you wish to implement, some of the less direct but more street level activities may be appropriate depending on the epidemiological situation in a given country and depending on the extent to which teams and field teams are able to maintain physical distancing measures whilst they're engaging in those activities. It is a very obvious challenge, and there are a lot of people doing work at the moment to explore creative ways to do remote risk communications and community engagement strategies or physically distanced ones. And there are resources available on that I can direct people towards afterwards if they want them.
Thank you. Another question that we received in advance is, what is the best way to collect and utilize informal qualitative data from, for example, networks for grassroots NGOs?
Okay, I'm happy to take that one. You know, as Hannah said, it's across the board. There are challenges to doing this as we would normally under other conditions. So whether it's collecting the data, whether it's distribution of information, engagement of communities, it is calling upon us to be creative and find other solutions. This is where partnerships like the one we have here, we hope will provide a platform and a means of accessing information, distributing risk communication guidance, and engaging meaningfully, because we will have to pool our resources, we will have to find creative ways of doing this together. In terms of qualitative research, it is a challenge. It is a challenge from the perspective of both the public health guidance that would suggest that bringing people together is not optimal at this moment. And it is a challenge also in the sense that some respondents are not comfortable speaking in their homes about issues that we would otherwise be able to collect in privacy. And in particular, I speak here about issues like violence and violence against women. We know that it's challenging to do this in the conditions under which we operate now. This is where even the methods by which we seek and get this information will need to be adapted. So the social media monitoring that Hannah has spoken about provides us one means of doing so. Others, there's engagement being done remotely to the extent that that's possible. Mobile phone surveys or, convening a small group of people through WhatsApp. Those are some of the other ways in which this information can be sought and is being sought at the moment.
Thank you, Nandita. Another question, how to use the data to craft easy messages to communities and to catch up with the necessary engagement of communities in a rapidly changing crisis. So can you talk about that, how the data and the information is changing very quickly? How do people craft messages that are relevant to their communities?
Okay, I can start, and then I'm sure my co-panelists will have other thoughts. The crisis is unfolding rapidly, and it is changing pretty quickly in terms of what people are experiencing. So information and rapid access to information is key. And this is where platforms such as this and the monitoring data, such as what will be available, both the monitoring data on the public health impacts, the epidemiological data, as well as the social data through mass media monitoring, all of that will be crucial. But there are some fundamental issues that will need to be addressed, and for the longer haul that cut across, that changes over time. And those are issues like maintaining personal risk perceptions that we know takes time to build, time to maintain at the adequate level, and it requires continual engagement with communities to ensure that. Others, maintaining social cohesion. Some of these messages and these issues will be relevant for a longer term. So using data where you can, addressing some of these fundamental issues to maintain public engagement will be the way to handle the changes in time.
Yeah, maybe I can just add a little bit. Sorry, Hannah, I saw you just jumped in there. But I think one of the things that is a little bit different about COVID as opposed to some of the other epidemics that we've all worked in is that the aim of COVID-19 messaging is not about getting to zero in many of the countries. There's a handful of countries, New Zealand probably being one, that have managed to get to zero and have a goal of staying at zero. Most of the countries are in what we call a suppression phase, which is to try to keep the caseload low and slow. And so there's key messages that we need to build around personal measures like we normally do around hand washing and respiratory etiquette. But I think there's a key message that we need to build up over time, which is that this is the start of a very long new normal, and messaging around what a new normal might look like and the changes that we're going to have to make in the long term, that there are going to be ups and downs in the wave of cases, and letting communities know that that's going to occur now, so that it's not a surprise, so that you don't lose trust from your sources. So being clear around the fact that we are still learning and that things will change, that this will be long term, I think is important. One of the things we are working on now with a number of countries is around getting clarity around risk levels to make communication easier and to be able to package different behaviours depending on epidemic prevalence. And South Africa has done a really great job of packaging this up, and we'll have a briefing note out on Monday to help guide countries around this, that communicating clearly around what the disease prevalence is and what the responsive behaviour from the community is in a consistent and clear, transparent way that governments can be accountable may be one tool to help balance out the difficulties of risk communication in a very dynamic outbreak.
And to add to all of that, alongside thinking very carefully about how you prepare communities to settle into that long haul and have that longer view strategy as risk communications teams, it's also important to remember that people's perceptions of this outbreak and the responses rolled out to combat it are going to change very, very rapidly. And that's where the data that we and others are producing can come in very helpful, because we are collecting real-time information and reporting on a very routine basis. So it will be possible for you as risk communications professionals to access information that tells you what people in your countries are saying and how their perceptions are changing over time, enabling you to craft very directed, targeted messages that are responsive to their needs. Another way that you can use the information to target your messaging is, for example, by identifying trusted sources. So we collect information from people about which types of people they are willing to accept information from, and the extent to which different channels or actors are trusted and seen as authorities in different countries. And therefore you can use that information to approach those people and engage with them to filter messaging down, rather than it coming from unknown faceless actors. We can help you direct your targeted risk communications at the people who are trusted to deliver them.
There's a question asking, do you recommend directly responding to myths, questions, and missing information with direct responses, such as a weekly fact sheet, in response to any informal qualitative information that may be gathered by a network of grassroots NGOs? So strategies around responding to myths, questions, and missing information, and whether it's good to give direct responses back.
It's a good question, and it's a question that I know we're grappling with a lot in this context of information overload. Every question seemingly has an answer on social media, and there's a lot of information that's pumped out, often without a lot of deep thinking or science to back it. But there's also data from the social sciences, social psychology in particular, that shows that the more often you repeat a certain axiom or a certain piece of information, the more it seems to have truth to it. And that applies to misinformation as well. So addressing misinformation is crucial. Countering misinformation may actually backfire. And so what that means, and therefore the recommendation, is proactive sharing of information via trusted sources, being honest about uncertainties and quick to provide that. Those are some of the means, the classic principles of effective risk communication will be the way to counter it without directly addressing or responding to it or giving it more life than it should have. And here, trusted sources are key, and maintaining trust is key.
Thank you, Nandita. Those are all the questions that we have in the Q&A right now. If the panelists would like to take a moment to make any closing comments, you're welcome now.
Sure, thank you, April. I saw in the chat box a number of questions about getting access to the local data and the report. So we'll make sure that we send that out, but the website is there, the preventepidemics.org COVID-19 PERC. The full report is there, and underneath that, there is a link to the Ipsos website that has the full survey and the country reports. The country briefing notes from PERC will be available on Monday. Given the large partnership that you've seen here, the external review and approval process has been slightly delayed, but those briefing notes should be out hopefully over the weekend, but if not Monday. So if you can check back on the website, the full PERC country reports will be available by Monday, but the Ipsos data reports with the detailed information that will be useful for the risk communications teams are available on that website, and I put them in the chat box as well.
I'll just add that I think it's, we're working in challenging times, and pooling resources, making information available, usable is key. And so I would just invite comments on what aspects of this data and this presentation have been useful, how we can continually provide information that will be most useful, and it would be helpful to hear from those that use the information to guide risk communication strategies, what they have learned as well. This is a two-way process in all senses of the word. And so I would just welcome both use of the data as well as feedback on how the data has been used and what has been found in actuality.
Nothing additional from me other than to say thank you all very much for joining us today.
Okay, thank you. That concludes our Q&A session. Thank you all, and back to Jobin.
Excellent. Thanks once again for everyone joining today. We really hope that you were able to use this time with us to understand a little bit more about why we've created this public-private partnership for evidence-based response against COVID, or PERC, and have had a sense of what the report findings are and how best you might be able to utilize that. Our intention here is to really learn with you in this moment of an evolving crisis, and figure out how best we can best be in partnership with you in making this information responsive and practical for your context. So there are two things you can do to help us take this forward. One is expect a communication from us in the next day or so that will have all of the links that our panelists referenced, recording of this session and slides from the session that you can share with your colleagues. And then one very critical request, which is in a moment when we close the webinar, you will be directed to a survey that asks you some quick questions to understand what you envision as being the next step for you from having learned this information, so we can best figure out and determine how we can be in partnership with you moving forward. So thank you so much for being part of today's session, and we hope you have a safe and restful day, evening, afternoon. Thank you very much.